So welcome everybody to another Awakening Your Health Potential episode. Today I have physiotherapist Simone Selby from Northbridge in Sydney, Australia. And we're going to talk about something that Simone and I, both in our professions, I'm a chiropractor for those that don't know, we constantly get asked what's the difference between physios and chiros. So I thought she was the perfect person to have this conversation with. And just for the record, Simone, you are the first physio I've ever been to. So that's been a really lovely introduction to physio with you for a bit of a chronic shoulder problem that I've had this year. So I'm going to hand it over to Simone now, and she's also done a lot of postgraduate stuff, but from the perspective of what's the difference between chiropractic and physio, we're going to be talking from very traditional standpoints, so you as the listener can get an understanding of how we're different and how things can overlap and how they work together really, really well, despite within our profession we often don't actually do that. So over to you, Simone, and maybe you can start with how long you've been a physiotherapist for and all the extra postgraduate stuff you have done in your career.
Yeah. Okay, so thank you, Sara. I've been practicing physio for 32 years. I started off as an intern at Royal North Shore Hospital, and hospital physiotherapy work is very different to being in a musculoskeletal therapy clinic. That sort of work is much more similar to chiro or osteo, where you're working on mainly sports injuries or neck and back pain. But 50% of physiotherapists actually work in hospitals on people following strokes or spinal injuries or following orthopedic surgery, just helping people with rehab whilst in hospitals. So that's a whole other huge area of physiotherapy. And these days, about 75% of physio graduates do spend some time in hospitals furthering their training, and about 25% go straight into private practice. So,
and how did you get into it, and what interested you in physio in the first place?
Okay, so I really enjoyed helping people. I was always a good listener, and, you know, if someone had a problem, I enjoyed helping them find a solution to it. I've never been good with blood and guts, so the hospital work was very challenging for me. If I saw a blood spill or gut spill, I'd have to get out of there, so that was bad. But I'm all right with calmly approaching someone in a lot of pain. I can help. I think my personality is just good at bringing a sense of calm and relaxation when they might be in pain, you know, helping them just breathe, relax, have trust that whatever's going on is transient and it will eventually heal. I think that's what drew me to physio. It just suited my personality. You have to be quite patient to be a physio, and you certainly have to be a good listener. Allow your clients the time to tell you everything they want to tell you about their body, and it may be 20 years of history, and you just need to allow them the time and the space to share. Which can be hard in a lot of traditional physiotherapy practices. You only have 20 minutes. And if you can imagine someone's got 20 years of chronic pain, that could take 20 minutes to go through. So it's about being able to listen but try and move them along to the current issue that they present with. So after the hospital, I worked overseas in London in a sports medicine practice. And then I came home and worked in very busy sports medicine practices in the CBD, Mossman and Northbridge. And then 20 years ago, I decided that regular physiotherapy and sports practices didn't suit me. I felt a bit rushed, and I didn't really like juggling 2 to 3 clients at a time. So I went out on my own. I studied Pilates and traditional Japanese acupuncture. And that all worked much better as a sole practitioner working from my own clinic, because I had the time to integrate the posture retraining and core strengthening with a bit of Eastern medicine and my knowledge of Western physiotherapy. So that brings me to now, to the year 2000, just trying to integrate everything in underneath the one umbrella.
So it's like you just have a few more tools in your toolbox that you can, add into a therapy session to just help push someone along the way a little bit quicker or as quickly as possible.
Yeah. And for me, my personal interest is in empowering people to have the tools to fix themselves. So, when they're in acute pain, of course, you need some manual therapy to help settle that acute episode, and then working together towards educating them to what's caused the problem and how to move forward through exercise therapy.
Well, I can totally relate to that as well. So that's a big part of my practice as a chiro as well, and pretty much a very similar path to you, I guess not that I didn't know I was a great listener when I was young, but, like friends at school would tell me that I had magical hands, and I really had no idea what that meant. I really had no idea, and I was a gymnast, and my cousin was a chiro, so I did some work experience with him, and as soon as I did that, I spent a week with him in his clinic in South Australia when I was in year 9. And that was it. It was like, oh, my God, I want to be part of this profession. And one lady came in and she could barely walk at the beginning of the week. And by the end of the week, she was walking so well. I just thought it was, like, amazing. So, but, yeah, totally. I kind of have been on a similar journey, with, working as a very fast-paced, which was kind of really, really great for my skills and developing my intuition initially. And then as I developed more tools in applied kinesiology and NET and Neuralink and a whole heap of other things, it became too hard to fit everything into 15 minutes. And so or even I used to actually see 2 every 15 minutes. And so now I see people, again, I don't juggle more than one person at a time, and I just feel like I can focus a bit more. So I haven't been in practice for quite as long as you. I'm up to 20 years this year. And but yeah, I feel like I've kind of come through that same sort of journey. So it's interesting. So for you, Simone, did you want to add something to that?
I was going to say, I think the client feels juggled when they know there's 2 or 3 others being treated at the same time. And of course, you and I are in a privileged position working for ourselves where we set our own appointments and decide how long we're going to give to particular clients. But I think the client feels it when you're, leaving them to quickly see someone else and then come back to them. And then, I think if someone's coming and giving you their body to work on, it's almost a respect thing that for the time they're booked in, they have your 100% attention and focus.
Yeah.
And for me, that's why busy sports practices weren't a good fit for me. Yet if you're seeing a physio just for a straight up knee rehab following, an arthroscopy or some sort of ligament repair, and most of your session is done in a gym in exercise therapy, then of course it's easy to juggle 2 or 3 clients. It's like a little exercise rehab session.
Yeah.
But if you're treating someone with a really chronic back or really chronic neck problem and it's really affecting every aspect of their life, you really need to be able to listen and give them your full attention. And also I think you need to be able to reassess as you're going through the treatment to make sure that the direction you're going in is having a positive effect.
Yeah. I mean, a lot of chiros work really fast, and I just think if the patient is improving and the chiro's working within integrity and it works for them, then, you know, I don't really have a problem with it. But for me personally, it's like I just got to a point where it was just too rush, you know, it was just too rush, too stressful. You know, if you start backing up patients, it's impossible to catch up. So I just like slowing down a little bit and just giving people that time. And I guess I do a bit more emotional work these days than I ever did, you know, when it's musculoskeletal and very structural as a chiro. And if you're just working with the spine, you know, there are things that you can do quite fast. Like the chiro that I just saw this morning, you know, it was probably 5 minutes, but sorted. But for me personally, you know, I prefer a more holistic approach in how I treat people.
Sarah,
yeah.
Can we just pause for a second?
Sure. So, Simone, from a traditional physiotherapy point of view, I don't want to say what the difference between chiro and physio, because I'll talk about the chiro side, but you talk about the physio side. What's the approach that as a physiotherapist that you take?
Okay, so first of all, the first thing you do is get a subjective examination. So you sit the client down, let them tell you their history, their musculoskeletal history. And you might get a little bit of their personal history, as in their profession and how that might relate to their pain or problem, and family history, as in how many children do they have, what age are they, have they had any serious operations or illnesses. And then as a physio, then your attention goes directly to the problem area. So, for example, if they've come in with, let's say, knee pain, then your whole treatment is going to be focused on the knee, all right? Unless their history made you think that it could be referred pain from their back, generally as a physiotherapist, you're just going to come in, you're going to look at the range of movement of the knee joint, you'll check the integrity of the ligaments around the knee, maybe do a couple of tests for the cartilage within the knee, and then you'll get on to some massaging of the knee, a bit of mobilisation of the joints around the knee, and then you might use some sort of electrotherapy. So for me, I would use laser, low-level laser, and then I'd use acupuncture. But in a physio clinic, normally they'd use some sort of machine to stimulate healing, an electronic machine to stimulate healing, and then you would prescribe the client a home program to strengthen whatever you think is weak around the knee, or you might prescribe some stretches, you know, to correct any imbalance in the knee. So that's just an example of, I think physiotherapy more takes the symptom and just focuses on the presenting symptom. And even if someone came into my clinic with, for example, chronic headaches, I'm 90% likely to focus on their neck and shoulders, maybe down to the thoracic spine as well. But most physios aren't going to look at the pelvis or the legs or think any further down past the mid-thoracic spine if they're presenting with headaches.
So in a situation where someone was, you know, I don't know, on a football field and they were tackled badly and they hurt their knee, that's totally relevant, right?
Then the physio would still be just looking at their knee, not at their pelvis or their spine.
It's an acute injury to the neck, an acute blow, so that makes sense.
Yes, but my understanding is as a chiropractor, you'd be looking at the rotational force in how they fell and what other parts of the spine are affected, whereas a physio, and even as an acupuncturist, I'm going to be mainly just looking at the area that's presented with the pain.
Yeah.
So even if someone came in with a 10-year history of headaches coming from their upper cervical spine, as a physiotherapist, you're mainly going to be looking at just the upper cervical spine. maybe addressing the thoracic spine if there's a postural component, if stiffness in the upper back is causing their head to be in a poor posture. You do some massage around the area of the neck and the shoulders, and possibly give them an exercise program to improve posture. But you really, especially in the first couple of sessions, you just go, as a physio, we focus on the problem area rather than looking into the whole picture, of why they might be suffering headaches. And I think that's the way physios work. There's no, you don't really go delving into the emotional components of pain, unless it's a particularly strong emotion that produces a particular postural pattern. Then you might be forced to look at grief or anger or something like that might make you, or exhaustion might make you a bit more hunched over. But I think that 99% of physios, if someone came in with cervical headaches, you're just going to be looking at the cervical spine and possibly the jaw.
Yeah.
So it's more, I think physio is more like taking the problem and just shining a spotlight on the problem area, treating the problem area, and if it does, only if it doesn't respond, would you go looking above and below for other contributing factors.
Okay, so that kind of makes sense to me as how I think of physio. So I think of physio as like if I refer a patient to a physio, it's because I want to accelerate healing. So I want them to do extra things that I don't do that's going to speed up healing or speed up a more of an anti-inflammatory response, so that inflammatory and the symptoms and the pain don't keep reproducing themselves, because that's not my specific skill area in terms of using, laser or ultrasound or any other type of device. So from a chiro point of view, generally the philosophy for chiros are that basically if you can start with the spine is the house of the brain and the nervous system, and all the nerves come out from there. So if someone, let's go stick with the knee point of view. So if someone came in and presented with a sore knee, I would be looking at, basically assessing the knee, like that's their presenting complaint. So doing my orthopedic tests and looking at alignment and muscle strength of all the muscles surrounding the area. But then I would always go looking at the foot, the hip, the pelvis, and then all the way up to the neck, because you can see these whole patterns with people. It would be silly to, and I think there probably are chiros that, there would be chiros actually that someone will present with a knee problem and they will only go to the pelvis or lower back. They may not do any peripheral sort of.
I think you've touched on the fundamental difference is. Yeah. You're looking for patterns.
Yeah.
Physiotherapists, we don't look for patterns.
Yeah.
A traditional university-trained physio is just looking at the musculoskeletal area that is presenting with the problem.
Yeah, yeah.
That you just would not even know about the patterns.
Yeah.
And it's particularly, some of it might be, physiotherapy is very evidence-based.
Yeah.
So there isn't some, concrete study showing a link between your little toe and the crown of the head, then you're not even going to think about the fact that, it's all the one body. You're just going to look at the issue that's the problem and get on to addressing that issue. And, for so many people, that's all they actually need for the particular injury that they've come into you with. And, some people will respond to that local treatment very effectively. Mm. And I think that's why, physio's often the very first port of call with injury.
Yeah.
My understanding is that people think that physiotherapy is like the safe first stop treatment, and it might be only if they don't respond to the physio
Then they look elsewhere.
Maybe I should see a chiropractor, but, I'd have to get one recommended. There's this fear.
Yeah, totally.
The type of people who come to me are scared of osteopathy or chiropractic. And, even when I offer them traditional acupuncture as a treatment, they look at me like, oh, how does that work? So...
Yeah, it's kind of out. I mean, if we look at the traditional medical model, the whole medical model, physio fits into that so well, because if you have a symptom, then you have a treatment for the symptom.
Yeah.
In terms of going to the doctor, if you have high blood pressure, there's a medicine that you take for high blood pressure. If you have, I don't know, if you have a sore leg, then there's a medicine that is for the sore leg. And so physio fits into the same principle of like, I have pain here, the problem's here, I need to do something about here. Whereas I don't think I'm even capable of like just looking at that bit. And maybe it's also part of the thing of, chiropractic, because of how far outside we look at these things, and we look at the involvement of, like, say, the knee, the hip, the foot, the pelvis, the lower back, and up the spine as well, because we're looking for the whole nervous system to be working better, and we're looking for mechanically the biomechanics of the whole system to be working better as well. So it's kind of, with most chiros, it's kind of twofold, that we're looking for the nervous system to be functioning better, and musculoskeletally or biomechanically things are working better. And I think the difference is, like, chiropractic has developed from a non-scientific, well, not non-scientific, that's not the right word, from a non-researched perspective. But now, as time has changed, there's a lot of we have to practice an evidence-based chiropractic and evidence-based treatments as well. So, a lot of chiros have become more like physios and less about the whole system. And so the very first chiropractor, he actually thought that he had cured deafness, because his first treatment was on a plumber who bumped his head under a cupboard, and he caused a subluxation or a misalignment with his upper neck, and he went deaf. And Dr. BJ Palmer adjusted him, and his hearing came back, so he thought he'd found a cure for deafness. But of course that's not relevant with every person who is deaf. And even my mum, she had a really bad car accident in her 20s, and she was nursing, and she went mute. So she couldn't speak at all. And my grandmother was seeing a chiropractor at the time, American-trained chiro, who was living in Australia before registration. And Nana was talking to him, and he said, we'll bring her in and we'll have a look at her. People, like all the doctors were saying, she had to go and see a psych, and she had to rethink her training. And she went to the chiro, and he adjusted her a couple of times, and she could speak again, it's quite miraculous. But also in those times when there was no registration, that particular chiropractor who was here before registration had someone come into his office and say, show me what you're doing. And he kind of showed him, thinking that he's educating people. And the guy went and set up a chiropractic clinic 2 doors down the road.
Right.
So things like that before registration, a lot of chiropractic itself got a really bad name because people weren't trained at all. Yeah. Like, they could literally stick up a sign and say they were a chiropractor. And so injuries would have happened for sure. I don't know what the statistics are. But yeah, things like, they're kind of where we came from has given the profession a bad name. So it's very common for me to go, I'm a skeptic. I'm here because it's my last resort. I don't really think anything's going to get better. And those ones are actually the easiest to work with because they're either expecting it to get worse from me working on them or stay the same. So if it gets better, they're like, oh my God, it's a miracle.
Yeah.
So how do you work with, like, do you get many people that are quite skeptical and it's like, you're my last resort? And
not at all. Well, because of the nature of my practice, I get people with a lot of chronic pain. So it is often, you know, the last stop that they come to. But I think for most physiotherapists working in private practice, there aren't too many miracle quick fix responses, you know, because we're working differently to you. So it's more because a lot of physiotherapy is the education and the retraining of whatever area is injured. The client has to go away and practice the exercise program, and then the physio might do more manual therapy, or they might just get the client back in to have that exercise program adjusted, you know, once a week or maybe twice a week. I think it's a much slower fix with physio, to be honest. I think possibly there could be a more educational component in the way a physio addresses the client. Like, I think in having had treatment with you, Sara, there's no way you could be educating me on what you're actually doing, because there's so much going on and I don't have an understanding of the way that you're working with the different nerves of the spine. So you just overwhelm your clients if you were talking about what you're actually doing as you're doing it, you know.
And look, I talk to you more than I talk to other people that don't understand.
You couldn't possibly educate them on, you know, what's going on in their pelvis with all the tiny little corrections and whatever.
And it's irrelevant as well, you know. Some people want to know the detail, and so those people, like, I will talk to about the detail more. But some people are like, they don't want to know. And then when I give people like exercises to help reinforce what I've done or to help the adjustment hold, I often will say, if I give you an exercise, will you do it? And some people say, yes, definitely. And some people say, nope, I just want to come back next week and have you fix it. And so those people, there's no point in me giving them 10 different exercises. But I might give them one or two. And I'm like, even if you just do this. And so, it's I mean, there are a lot of, chiropractic is so diverse within the profession, and I'm sure physio is as well.
It is the same,
It's so diverse, and some chiros are chiros that adjust the joints and the spine and do physio type work as well, and set rehab programs. I used to set a lot of rehab programs because that was also exercise physiology was my undergraduate degree, so I used to do a lot of that stuff as well. But now I prefer to hand that over to, you know, a physiotherapist or a personal trainer or an exercise physiologist in terms of that side of things. And then other chiros literally are only adjust the spine and they're 5 minutes in and out, and that's what they do. And, you know, and then there's kind of the ones that are a bit more like me, they're a bit more holistic, and it's like we were working out, like, is there an emotional component? Is this inflammatory pain in the knee to do with what they're putting in their body, or because their gallbladder's not working properly, or you know, they just inflame, they need to work on some anti-inflammatory supplements or foods or something like that? Or is it just structural, where I adjust the knee, the foot, the hip, the pelvis or whatever, and then off they go? So, you know, it's all professions are quite diverse, but I mean, chiropractic is known for being, that's why people want a referral, because they want to know what they're getting, because we're so diverse. There's over 100 chiropractic techniques. So, you know, it's one chiropractor can be so different from another chiropractor.
I do think that there is a different type of client that would be open to seeing chiropractor, and then there are other clients who would never go and see a chiropractor. Even if they're seeing a physiotherapist and they're not improving, they'd probably prefer to end up in having a, you know, injection under anaesthetic or a surgery or something before they'd see a chiro. And it's just lack of education, to be honest. You know, it comes from that fear. I think that a lot of GPs need to be better educated about what chiropractors actually do. GPs are barely educated on what physiotherapists do.
Yeah.
You know, like
But it fits the model, so it's kind of, even if they don't get it, it still fits the model, so it's kind of like it's easy to.
I know, but still GPs under-refer to physiotherapists. They're more like, if someone comes in with back pain, they're more likely to prescribe them a 2-week course of Voltaren or other anti-inflammatories, get an MRI or CAT scan or some other kind of invasive procedure or expensive procedure when, irrelevant of the MRI result or the CT scan result, the person is highly likely going to respond to a course of physiotherapy. Absolutely. But I have found in my 30 years that a lot of people are under-referred, even with something common like a sprained ankle, which responds so well to physiotherapy. We can use some strapping tape and, you know, get them onto some safe weight-bearing, you know, exercise again. It's actually vital that a sprained ankle has quick physiotherapy intervention.
Absolutely.
And yet a lot of hospital departments or GPs just give them a pair of crutches, a bit of tubey grip, elasticated bandage and send them off. That's it.
Yeah.
So I think, you know, physios have been trying to educate the medical profession for 100 years to refer more clients. So I think that the chiro profession has a lot of education to do.
Oh yeah, yeah, totally. And look, I think the other issue within, like, you know, a GP has just started seeing me recently. I think I've seen her a couple of times, and she's asking me some really interesting questions. And she said last night when I saw her, she said, oh, you know, what was she asking to refer? Something to do with feet, I think. Oh, that's right. She was asking for herself about whether she needed a heel lift because she's got a leg length difference. And then she said, you know, what about people who have foot problems? Can I send them to you? And I'm like, yeah, of course you can send them to me. And I said, but, you know, you could look at the foot if you wanted to kind of start to think about this yourself. You could actually look at the feet and you will start to actually understand, is this a primary foot problem where the foot is unstable, the foot is unsafe, like it's got massive bunions on it, it's really flat, it's degenerated. And if it's that type of foot, they're probably better off going to a podiatrist. However, if it's a reasonably healthy looking foot or there's one foot that's different to the other, then that's going to create a lot of issues all the way up. Then that would be relevant for me. But if you're not sure, you can send them to me and I'll be able to kind of work that out. And the foot that's unstable and unsafe needs to see an expert in the foot, which is a podiatrist. So, but it was kind of very interesting conversations that she's kind of trying to work out, like, these kind of musculoskeletal people, you know, can she send them to me for me to then work out, you know, do I work with them? Do I send it to a physio? Do I send it to a podiatrist? Because it's so out of her scope of practice, just really basic musculoskeletal complaints.
However,
it's a good thought because at least she's not going, well, let's just do a course of anti-inflammatories. Let's actually do something about it.
The majority of people with a sore foot go straight to their GP.
Yeah, I know. Yeah. The majority of people with a sore anything or something, right? I mean, yeah, that's right. So, yeah, I mean, GPs, you know, are general practitioners and they know a little bit of lots of things, but it's understanding about, you know, where is the best, what type of practitioner is the best one. And I think a lot of primary health practitioners, like people like you and me and podiatrists, and they can really be sent to any of those because those will then go, okay, this isn't really me. You need to go and see this person. And hopefully, like, that's kind of my intention of being a chiropractor. It's like, if this isn't my thing, then I send them to the right person. Or if this person isn't responding, I know you're like this as well. If this person isn't responding within a few treatments as I expect, then what else do they need? Do we need to do some scans? Do we need to send them to a physio? Do we need to send them to another type of practitioner to actually get them this speed of improvement that I expect the human body to do innately?
Yeah. I think from both of our points of view, I'm not a believer in things getting worse in order to get better.
Yeah.
Like, I don't know who made up that fallacy, but I think if your client needs to be responding in the positive direction after every single treatment.
Yeah.
A little bit of soreness from, deep massage is acceptable, but not a worsening of their symptoms after each session, So you'd want to, as a physiotherapist, I'd really want to see someone, if not 100% after, 3 sessions, to be definitely nearly 100% or definitely feeling that positive changes on its way.
Yeah.
Or else at that point I'd already be starting to think, what have I missed? What else is going on here? Do they need further investigation?
Yeah.
Etc. I'm certainly never been one to keep someone having treatment forever if they're not responding.
Yeah.
And, ultimately the clients will, they don't want to keep paying for treatment if they're not responding.
Yeah. But you're often that kind of become that safe port of call of like, I'm not sure what's going on, so I'm going to go see Simone or I'm going to go see Sara because I don't know what's going on. And so when you build up that trust, you become that person's primary healthcare practitioner, which is great. But yeah, I think it's I'm the same, people, I've seen families and, 3-4 generations of the same family over the 20 years, not because I'm always working on the same thing, but because different things come up in life, and you become that person that is the safe point to start to then go in whatever direction they need to go in. So I thought another fun thing to talk to you about, which we often talk about, our own little spiral lines and that type of thing, is my fascial trains. And we both love this book called, if you're watching on YouTube, called Anatomy Trains. Simone's got the even earlier version of mine. And it talks about a fairly new concept about fascia. So for those that haven't really looked at fascia, it's kind of like it's the tough material that surrounds things like muscles, ligaments, tendons, the spinal cord, and it attaches to the bony parts of the body. And the way I actually hate cutting up meat for food, but if I do, we often get a eye fillet, like a big long eye fillet from Harris Farm, and you can actually see the fascia along that, because I think it is the psoas muscle, the eye fillet of the cow, and you can actually see the fascia and how tough it is. It's such a tough material, so it really can cause a big widespread patterns, which Thomas Myers has termed the myofascial lines and the anatomy trains in this book. So do you want to talk about that a little bit?
Yeah, like my understanding of the fascia is it's the connective tissue that literally joins the skin to the bones via the muscles, right? So if you hold your arm out in front of you and draw your fingers down to the floor, the skin stretches over here. It's the fascia that runs over the back of the hand and up through the arm that's pulling the skin, My interest in fascia is tied in with my interest in acupuncture, because the latest research on trying to find where energy flows along the acupuncture meridians, we're actually finding some breakthroughs in thinking that possibly the acupuncture meridians are very close to the fascial planes in the body. So,
because often those acupuncture points are in those dips between the fascia, aren't they?
So the acupuncture points are in the spaces, like you're inserting a needle into a space, and it's the spaces between the between fascia.
The fascia. Oh, right. Okay.
It's almost like you're finding the spaces that run throughout the body and
making sure they're kind of gliding and sliding properly. Yeah, so interfascial adhesions get nasty.
Acupuncture is about blood flow. So you just want, if you can get better blood flow to an injured area, it means you're getting more oxygen into the injured area and the body has the wisdom to heal that injured area.
On that note, I might just mention, I know I'm backtracking a little bit, but then the other question that I often get asked is what's the difference between osteo? And you've just reminded me to talk about that, because the main difference between chiro and osteo is the philosophy around osteo is increasing blood flow. So osteos will do a lot of massage. Their adjustments are quite generalized. They're aiming to get most of the joints in the lower back when they do a big lumbar adjustment, and most of the joints in the neck one way, and then most of the joints in the neck the other way, because they're interested in increasing the blood flow. Whereas chiros are interested in normalizing the nervous system, or a subluxation, which is basically a misalignment that has other components that are related to it. So it's like trying to correct the areas that are causing the problem. So that's just a side note that I thought I should explain as well.
I think the myofascial trains, Thomas Meyer's work, he uses a lot of yoga poses. So it's interesting that, I mean, yoga is 4,000 years old, right? So it's almost like all those years ago, the yogis understood that the body benefited from a set of exercises that stretched from the tip of your toes on the right to the tips of your fingers on the left, or stretching from the crown of the head to the soles of the feet was of benefit. And, you know, to me, I really enjoy the myofascial trains because it's looking at the body very holistically. It's saying that, for example, you can't have plantar fasciitis. Like, plantar fasciitis can never be a problem only with the plantar fascia.
Of course.
If you've got plantar fasciitis and you've got problems in the fascia, if the entire back line of the body, you know, inflammation and tightness in that sole of the foot will have an effect on the crown of the head.
And that's why one of my homework exercises for people with plantar fasciitis is downward dog.
Yes, that's right.
Because it's that how you can feel it all the way along.
Yeah. A lot of my clients are completely surprised when I give them calf stretches for their plantar fasciitis. They think that just massaging a ball in the plantar fascia is going to fix the problem.
Yeah.
And
fascia is tough. You know, it doesn't have much blood flow, and it takes
slow stretching.
Yes.
Slow.
Yeah.
I always tell people to imagine the fascia is a little bit like glad wrap. You know, if you hold a bit of glad wrap between your hands and tug it hard and fast, it's never going to stretch. It doesn't do anything.
Okay, I've never done it.
Take your glad wrap and you pull it slowly apart with consistent pressure, then you can get your glad wrap to stretch a long way before it tears.
Right, okay.
And the fascia responds in the same way.
Okay.
It really likes slow, sustained stretching, which is really similar to hatha yoga as well. That's slow, you know, slow stretching. And it loves slow pressure. Like there's all, you know, the Pilates foam roller. It's a superb piece of equipment for massaging the fascia of the body.
What a great invention that was.
Yeah. It's really nice. You know, and although a lot of people find it painful, I think intuitively they just know, they feel so good when they've rolled something out that was tight using that.
Totally. And it responds so well. Like, it responds so quickly and so well, and it's so easy for people to do at home. Like, it's such a simple, fabulous invention.
Yeah. And it's much more comfortable than a deep connective tissue massage performed by a physio or osteo or chiro, that's uncomfortable.
Yeah.
But, it empowers people to be able to work on their tissues, a little less, but doing it more regularly. So every day, starting to work through your hamstrings and your calves.
Yeah.
And, I think a lot of plantar fasciitis would, for example, clear up very nicely and remain better permanently if you address the tightness in the entire backs of the legs and the back of the body,
Yeah.
But, yes, I do love that book. And I think when I show my clients the images in it, they get a better understanding of how the foot attaches to the calf, which attaches to the thigh, which attaches to the pelvis, which attaches to the buttock cheek. And although we all know that, it's common sense. If you have pain somewhere, it's very hard. You just think about where the pain is. You don't think of its relationship to the rest of the body.
On that note, Simone, can you your pattern, like your fascial pattern that you know so well, can you describe that for people? Because I think also people just go, I've got all these sore spots and they're all unrelated and I'm falling apart. So can you talk about your pattern that shows up for you? Because it might help people actually join those dots.
Okay, so my classic postural pattern that I've lovingly built in my body over my 54 years, for some reason my body's adopted this posture, is what we call a spiral line. So that's a rotation through, it starts down in your foot, and it's a rotating up through the legs, through the pelvis, through the ribs, and up into the occiput.
So how does it present for you?
Okay, so the way it presents, starting down in my left foot, I roll in my left ankle.
Yeah, but you know this because you're a physio. How do you know when it's going off?
Oh, when my spiral line is out, I catch myself standing with my pelvis twisted about 45 degrees to the left.
Uh-huh.
So,
and what happens up here?
Oh, yeah, it presents as like a headache.
Yeah.
Up on the head with a lot of tension through all the scalp muscles, the jaw tightens up. But the most obvious thing, aside from the painful symptoms that it produces for me, is that I catch myself walking around with my pelvis rotating to the left. So at such a strong degree that if my pelvis was the headlamps of a car, they'd be pointing off into the curb, and it's just kind of creeps up on me, and then I'll realise I've gotten into that pattern. And obviously you can't walk around with your pelvis pointing to the left. At some point your rib cage needs to rotate to the right, and then that means that my head has to then rotate left so that my eyes look straight ahead. Yeah. And so that's my basic pattern. And when you walk around with those kind of twists in your spine, you're going to feel tension somewhere. And for me personally, I feel it up in the temple region and up in my occiput, base of the skull. Yeah. So,
you've got a few points along the way. It's like I remember the very first time I worked on it with you more recently is like that foot. The foot, I can't remember what part of the foot. Was it like the navicular or in the arch, or it's
the fifth metatarsus gets tight on the right.
Yeah.
But I do it's very complicated, but the whole thing, the beginning of my spiral line is rolling in on the left foot.
Yeah. It's
so I tend to
those ribs as well. Those kind of ribs go and they
get. Well, the thing is,
the left one gets tender at the front.
Yeah. The thing about human beings is that we're so visually, our eyes have to go straight ahead.
Yeah.
So no matter what direction your feet are pointing in or your pelvis is pointing in, by the time you come up to your head, the eyes must go straight. Because we can't walk around with our head following a twist.
Or if someone's got a bad scoliosis, like you can't
but your head will,
around like.
Yeah, the eyes will always level out.
You know what? Have you ever felt someone's neck who is like blind in one eye?
No, I don't think I have, but it probably feels...
So if they're blind in one eye, like just say this one's my blind one, then they turn their head to get all the visual input into their right eye, into their good eye, so their neck gets so rotated.
Right.
Whereas, you know, if your vision's pretty good, even if with a dominant eye, most of us are dominant in one eye, we'll often get some rotation because automatically you might kind of lead with one eye. So, yeah, it's so obvious when someone's got really bad vision in one eye.
Yeah, but I think like the body will do remarkable gymnastics to make sure that your eyes go straight ahead. Absolutely. You know, your knees can be pointing off in the wrong direction, pelvis going in another direction, ribs doing something else. But because most of us are completely, our reality is what our eyes feed us.
Yeah, absolutely.
You know, if simple exercises, if you make someone stand, you know, with their eyes closed, you know, your body starts to move and sway from side to side. If you ask that person with their eyes shut to lift one foot off the floor, even a fit, strong person who thinks they've got fabulous balance will fall over within about 10 seconds or, you know, start to wobble crazily within 10 seconds. Mm. So we do rely so much on our eyes for balance, for, you know, everything else, alignment of the spine, you know.
Yeah.
So I think, you know, going back to that spiral line, it's amazing how many rotations the body will have to do to make sure that the eyes end up pointing straight ahead.
Yeah, absolutely.
And you know, mine's quite extreme pattern. I think it's extreme. You may not think it's extreme. I probably see it all the time as a chiro. But I think that a lot of people have spiral line issues and have no idea. I've found in physiotherapy, tight right sacroiliac joint is always tight left occiput. And so I'm almost always seeing that diagonal patterning. And it's for that same reason I just described. If your pelvis is pointing to the left, then at some point your head has to turn back towards the right.
Yeah. So, and that can be like those spiral lines, but it can also be the dura inside the spinal cord as well. So, but again, it's still fascia. It's still the same stuff, the same material that you're working with.
Yeah. I think the fascia, there's a lot of research into it now, and we're really starting to see, because, you know, all the organs are enclosed in fascia as well.
Of course, yes.
So, you know, everything, if we, they've actually just started mapping the fascia, the whole body's fascia. And when I studied anatomy over 30 years ago, we learned about the vascular system, the nervous system, the skeletal system, and the muscular system.
Yeah.
But we never saw an anatomical drawing of the fascia.
No.
And the thing is, it's actually the same. Just like the muscles of all human beings are exactly the same, the fascia is pretty much exactly the same in all people too. So it is a very...
system. It is its own system.
It is its own
and
system.
Structure. Yeah, totally.
Yeah. And it's a vast network. A huge network. And I think, you know, really in just the last 5 years, maybe 5 to 10 years, it's really been brought to the attention of a lot of physiotherapists, chiropractors, osteopaths.
Body workers.
Yeah, I think Tom Myers was a bit of a leader
big time
in the field, definitely.
Absolutely. Yeah.
And I think, you know, his work, it's a very visual textbook.
Yeah.
And so that quite appealed to me. You know, you can read, you know, anatomical terminology till the cows come home and not get a good idea of how it works. But I think his book is visual.
Yeah.
And it allows you
to literally like see a person in front of you.
Yeah.
And visualize that fascia when you know the human body quite well as well. So it's a really great visual book. So any practitioners that are listening or any non-practitioners that are listening that are interested in fascia or kind of thinking, oh, I get this and this, and it kind of always follows this pattern, but it could start off anywhere along that line. You're possibly looking at a myofascial pattern, and
I think
maybe seeking a practitioner that works with that if you want some help with it, or doing some of the things that Simone suggested with really long, slow, or yoga, hatha and yin, those type of things are really great.
There's a form of massage therapy called rolfing.
Yeah.
And that's, they were working on the fascia many years ago. Yeah. But they were such a minority.
Does Bowen work on fascia as well?
Beg your pardon?
Does Bowen work on fascia as well?
No. That's different again. They do flick the fascia, but it's more about just movement. Okay. I think they're more working like on a sacrocranial level. Okay. But, a rolfer presses down deep into the tissues and then asks the client to move, their extremities forwards and backward to draw a strong, deep pressure through the fascia. And I think, in fact, they were the first lot of body workers to
work with that,
start to look at how the feet connected to the crown of the head and through the myofascia.
Another one that's developed, there's gua sha. They would have been working with that, in Chinese medicine. And then more recently there's FACTR, which is FAKTR. I can't think what it stands for at the moment, but they use a lot of tools, I guess, based more on gua sha and the Chinese medicine sort of model, and working through fascia as well. So there's certainly a lot of developments and people working in this area, and so it's really fascinating. It's going to be great to see it develop further, because it's one of our little things that we chat about quite a lot, you and me. So I thought that might be a fun thing to talk about.
I think it'll be interesting to see if it makes its way into the undergraduate degrees.
Oh yeah, that's true. Yeah.
So actually included in the anatomical training.
Yeah. At some stage I'm sure it will actually. Yeah. Not yet.
It certainly wasn't something we were looking at when I did my anatomy training. The fascia was something you had to cut out of the way in order to.
So true. Yeah. That's just the surrounding layer you don't need.
Yes.
We need to look at the muscles and the muscle fibers and how that's all working.
Yeah.
Well, thank you, Simone. There's been a great chat with you as usual, and so I hope people have found it interesting and got a couple of take home things. And do you have where can people find you if they want to look you up?
They can just look up Simone Selby Physiotherapy. If they Google that, they'll find me.
Okay.
The practice is actually in Castle Crag, Sarah. Next door suburb to Northbridge.
Okay.
But
Do you on social media at all?
No.
Do you have
I'm not a high tech person.
Do you have an email if someone wants to contact you?
No. If they Google Simone Selby Physiotherapy, they'll find it.
There you go. Okay. Awesome. Well, thanks so much for your chat today and your time.
My pleasure.
And
we'll talk soon.
We will talk soon.
Okay, bye.
If you loved or learnt something in this episode, share it. And don't forget to subscribe. I look forward to bringing you next week's Awakening Conversation. Have a wonderful week.